Hi, this is Dr. Haggard, and I'm excited to welcome you to a new era of weight loss. This is the history of FDA approved long term medications for weight loss, starting with Orlistat in 1991 to tirzepatide today, 2023. These medications are typically taken orally, and these over here are taken by injection. The difference, though, is staggering. You have from 4 to 8% weight loss. And in these category of medicines, we're seeing 8 to 21% weight loss. These are huge differences. Here are the details of that slide. We have first the generic name, followed by the brand name, the year it was released, the amount of weight loss, and then typical weight loss you actually see in some of those studies. And again, this is also dependent on what the person's baseline weight was that took the medication in those research trials. We're going to be focusing in this lecture on these last three medicines because these are the newest big players that are producing almost double the results of these previous medicines. Tirzepatide is the first medicine to be compared to bariatric surgery results. Lap band surgery, on average, produces about 17% weight loss. Sleeve gastrectomy is about 25%, and gastric bypass is around 33%. And this falls in that category, and some of the other trials are even a little higher. So, the start of this new era of medications are the GLP-1 receptor agonist, and that stands for glucagon-like peptide 1 receptor agonist. And they have five main effects. They help regulate appetite, they lower glucose, increase satiety, slow gut motility, and upregulate insulin secretion. The GLP-1 receptor agonists are mainly liraglutide and semaglutide, and they have a 90% homology to the natural GLP-1 that's found in the human body. However, they're chemically modified to increase the half-life, which is what causes them to stimulate weight loss. These medications were initially approved as type 2 diabetes medications. However, besides the glucose management aspect of these medications, they were also found to significantly reduce weight in type 2 diabetes. So researchers asked the question if these medications could be used for weight loss in non-diabetics. So in this study, they gave 3,700 obese or overweight non-diabetic adults over 56 weeks either placebo or the liraglutide daily injection at 3 milligrams. Here are the results. The placebo group, because also they did have lifestyle interventions of diet and physical activity, and that did have some results for the placebo group, but not that significant. Only a 2.6% weight loss over the course of 52 weeks. But the liraglutide group lost 8% on average of their weight. The liraglutide group did report a high degree of adverse events. 80% of the people reported these, and the main events were GI related and typically nausea, diarrhea, constipation, and vomiting. The adverse events are common with these medications, but most of the time they're only mild or moderate in severity. So then researchers asked the question if semaglutide could be used for weight loss. Again, previously proven in a type 2 diabetic population to be effective. So in 68 weeks, they gave about 1,900 people that were obese or overweight either placebo or semaglutide injection. And the results were similar to the other group where we saw about a 2.4% weight loss with the placebo group. However, here we see a lot more weight loss with the semaglutide, down to about 15% of their baseline body weight. Similarly, we saw a lot of adverse events with the semaglutide group. About 90% reported these. And 75% of those 90% of events were the same thing, GI related, nausea, diarrhea, vomiting, constipation. So these adverse events are common, again, with the semaglutide group, but mostly mild to moderate. The GLP-1 receptor agonists cause these typical GI events because of the decreased appetite, a slower gastric emptying, and then constipation is common because you're just consuming less volume of food. And these events typically occur in the first 4 weeks and when you increase the dose after you have established a regular dosing schedule. One strategy we found to reduce the adverse events during the increased doses is to split the new dose over 2 injections. So for example, if you have a person that is injecting once a week on Sunday and you would like to increase the dose, have them do the same dose that they were doing for the previous time period, but then whatever the additional amount is, maybe do that 3 days later. So again, maybe on Sunday you take the dose that they were regularly doing and then you want to increase it, let's say by a half or whatever milligrams. You would do the extra dosing maybe on Wednesday. Treating both non-diabetics and type 2 diabetics over a 6-month period at Mayo Clinic using various doses of semaglutide revealed some interesting findings. This was the various doses that they used. The doctors at Mayo Clinic were giving minimal doses all the way to the max dose, and here's the number of patients in the cohort, or again, if you look at it percentage wise, you can see the percentage in parentheses. And the majority of the patients received middle of the road dose, which is 1 milligram. And what they saw was that with similar dosing, the type 2 diabetics lost less weight than the non-diabetics. So type 2 diabetics lost about 7% of their body weight over 6 months, whereas the non-diabetics lost almost 12%. On the lower doses, they also noticed there was lower weight loss. So lower doses, meaning 1 milligram and less, they produced 5% weight loss in 3 months, whereas the higher doses were at 7%. And then at the 6-month mark, we see the lower doses eventually helped people get more weight loss at 9%, and the higher doses were at 12%. In this cohort of patients, only 48% of the patients reported adverse events. And when you compare that to the step 1 trial at 90%, it definitely seems that the adverse events are dose related. In addition, the doctors that published this trial from the Mayo Clinic also reported that reducing the dose helped people when they did have adverse events. Then researchers asked, what happens if you stop taking a GLP-1 receptor agonist? That's what the step 4 trial investigated. So after 20 weeks of about 10% weight loss using semaglutide, 2.4 milligrams weekly injected, they randomized about 800 participants for 48 weeks to either placebo or to continue the semaglutide weekly injection. And what they found was that the placebo group, after the run-in period and lost about 10% of their weight, slowly gained the weight back up to 6.9% weight regain, whereas the semaglutide group continued to lose weight and they lost an additional almost 8%. So on average, they were about 18% less than their baseline over the course of the 68 weeks. Then they asked, can you take a GLP-1 receptor agonist long term? So for 2 years, they took about 300 overweight non-diabetic adults and they gave them either placebo or semaglutide injections. The placebo group lost about 2.6% of their weight. Again, they were doing other lifestyle interventions as well. Whereas the semaglutide group lost 15% of their weight over the 2-year period. The semaglutide weekly injection at 2.4 milligrams, again, reported a very high amount of adverse effects. 82% of the people reported these. Again, these were all the same as the previous ones: nausea, diarrhea, constipation, and vomiting. Mostly were mild to moderate GI symptoms. However, to point out that these adverse effects are common, especially the higher you dose the medications. Then researchers asked which one would produce better weight loss in non-diabetics. So they did a head-to-head trial of liraglutide and semaglutide in the STEP 8 trial. And they compared over 300 non-diabetic adults for 68 weeks, giving them the max injections for these doses for the liraglutide and the semaglutide. The liraglutide produced on average about 6.4% weight loss, whereas the semaglutide averaged about 15%, almost 16% weight loss. So in a head-to-head trial, keeping everything else the same, the semaglutide outperformed the liraglutide for weight loss. Then researchers asked if adolescents could safely take semaglutide. That was the STEP Teens trial. 180 adults or adolescents aged 12 to 18 with obesity in the 85th percentile for their age for 68 weeks were randomized to placebo or semaglutide. And the placebo group actually gained weight, almost 0.6, they're almost 1%, and whereas the semaglutide group lost a staggering 16% of their weight. The other thing to notice, though, is that when they stopped the trial and they monitored them for a few more weeks, there was weight regain similar to the other studies. So semaglutide adverse effects in adolescents also were reported pretty high, 62%, and luckily they mostly were mild to moderate, but again, these adverse effects are common with these medications. So the answer is yes, adolescents can take semaglutide for weight loss, and in December of 2022, the FDA approved semaglutide as the first injectable anti-obesity prescription medication with a once-weekly dosing for use in pediatric patients. Cautions for the GLP-1 receptor agonist group of medications. If somebody has a history of multiple endocrine neoplasia 2 or medullary thyroid cancer, that could be a caution or a contraindication. And then also on the label, there is an increased risk of thyroid cancer due to the rat model that was investigated before it was given to humans. However, I want to emphasize that these medications have not shown an increase in thyroid cancer in humans. However, because of the rat model, the warning remains on the label. Also, pregnancy is contraindicated due to insufficient data. Here is the first study that helps offset that rat model warning label. They did a meta-analysis of type 2 diabetic trials, and there were 34 articles which totaled over 50,000 patients. And they compared these patients who had received placebo or other interventions with people who actually were given the GLP-1 receptor agonist, and they found no increase in malignant neoplasm in the people taking these medications. The conclusion of this meta-analysis was GLP-1 receptor agonists can be used without safety concerns related to malignant neoplasia in patients with type 2 diabetes. The second study that counters this whole idea of thyroid cancer with these medications is this semaglutide in cancer systematic review and meta-analysis. They took 37 randomized controlled trials and 19 real-world studies, which included over 16,000 placebo-controlled patients, 16,000 patients in the active groups, and then over 13,000 patients in real-world studies. And their conclusion was semaglutide use in randomized controlled trials and real-world studies was not associated with an increased risk of any types of cancer. And this conclusion is supported by high-grade evidence. So furthering the cautions here are any known or active gallbladder disease. The use of a GLP-1 receptor agonist may increase the risk for reoccurrence. Also, it's theoretical that pancreatitis could be a problem, but this has not been definitively proven yet in any of these studies. Also, retinopathy could be a problem, and if somebody already has an issue with delayed gastric emptying, that could exacerbate that. And then the last one on the list is taking insulin or insulin secretagogues could be a caution or even a contraindication, as they may increase low blood sugar problems. Next, we have tirzepatide. Tirzepatide is a dual receptor agonist, so it has the same action that the liraglutide and the semaglutide does, but in addition to the GLP-1 receptor agonist, it also acts on the GIP receptor agonist, which is the gastric inhibitory peptide. Now, compared to the first generation of GLP-1 receptor agonist, tirzepatide has shown to have an unprecedented effect on hemoglobin A1C, which is how we monitor long-term blood sugar in diabetics, and body weight. So researchers asked, same thing, will this medication possibly reduce weight in non-diabetic patients? So for over 72 weeks, they took about 2,500 overweight non-diabetics, and they gave them either a placebo, tirzepatide at 5 milligrams, 10 milligrams, or 15 milligrams per week using a subcutaneous injection. And here are the results. The placebo group lost, similarly to the other ones, about 3%, so that's the lifestyle intervention part. The tirzepatide 5 milligram lost 15% of their body weight. The 10 milligram almost 20%, and the 15 milligram almost 21%. So note here that the difference between the 10 milligram and the 15 milligram group isn't that significant. However, here we also see in this chart that 30%, so looking over here at the adults that lost at least 20% of their weight, 30% were able to achieve that in the 5 milligram group. And then 50% achieved that in the 10 milligram and 56% in the 15 milligram per week dose. And then at the last one here, more than 25% of their weight loss, 15% on the 5 milligram group were able to achieve that, and then 32 and 36 for the 10 and 15 milligram. But what I want to point out is there's just not that big of a difference between the 10 milligram and 15 milligram groups. So the problems with these lifestyle intervention trials when they don't use medications, and when I say lifestyle interventions, we're talking about calorie restriction, physical activity, and behavioral counseling. The problem is that large weight reductions are critical in order to have an actual benefit for obesity-related complications such as obstructive sleep apnea or non-alcoholic steatohepatitis, NASH. And then also for decreasing cardiovascular deaths. You need to have a significant amount of weight loss, and when you do these lifestyle interventions, on average, less than 20% of patients will lose the required 15% or more of their baseline weight to have those benefits. In addition, most of these lifestyle intervention studies show that most people regain a third of the weight they lost in the year following treatment, with increasing weight regain over time. And they conclude repeatedly that the weight regain is attributed to hormones. So researchers asked what happens if you take tirzepatide after weight loss. This was the SURMOUNT-3 trial. After 12 weeks of weight loss with an intensive lifestyle intervention, again, no medication up to the 12-week mark, then they had adults, about almost 600 adults, either take placebo or tirzepatide at various doses for 72 weeks. And here's what they found. The placebo group, it was a very light line, so I added an orange line here just so you could see that's where it's at. And then this arrow shows where the intervention started after the patients were able to lose a little over 5% of their body weight on average, but at least 5% in order to be included into the trial. And they found that the placebo group saw a 3.3% weight regain, which is typically what we see in these lifestyle intervention studies. However, after the lifestyle intervention weight loss and then beginning the tirzepatide group continued to lose an additional 18%. So from baseline, they were able to achieve a loss of 25% of their body weight. Similar to the GLP-1 receptor agonist studies, researchers asked the question, what happens if you stop taking the dual agonist? So after 36 weeks of weight loss using weekly tirzepatide injections, they took over 750 adults for 52 weeks and they randomized them to either placebo or to continue the tirzepatide weekly injections. This data has been published on Eli Lilly's website, but they actually haven't published the results yet. This just occurred. However, the SURMOUNT-4 trial data shows that the baseline weight of the participants on average was 236 pounds, and the amount of weight loss they experienced at 36 weeks was about 20%. So on average, they weighed about 187 when they started the new intervention, which was either placebo or tirzepatide continuation. The placebo group saw a weight regain of about 9% or 22 pounds. So even though they're less than their baseline weight, it seems like over time, these particular medications, when you discontinue them, you see most people regain the weight. The tirzepatide group, however, when they continued the tirzepatide, they continued to lose weight, and they saw an additional almost 6% weight loss, or about 13 pounds, continuing over the time period, which gave this group a total of 26% less than their baseline weight when they started, or again, on average, about 62 pounds of weight loss. Now, what's interesting is all of these placebo groups receive the same dietary advice in all of these studies. And it's interesting because with good dietary advice and also physical activity and behavioral counseling, I kind of expected over the course of this time period, 72 weeks, that these people might lose more than on average 7 pounds. And so my question was, what is the dietary advice they're given? The dietary advice was the same on all the studies. It was 30% of the energy should come from fat, 20% of the energy comes from protein, and 50% from carbohydrates, and they should be focused on an energy deficit of at least 500 calories a day. However, Gary Taubes has shown the evidence in multiple books that being obese or overweight is primarily a hormonal problem, not a calorie problem. So in his book, The Case for Keto, he addresses this and recommends that eating a low-carb, high-fat diet can address this primary hormonal issue. We commonly recommend this book when patients begin these weight loss injections in order to enhance the effects, especially the satiety effect. So Taubes shows consuming carbohydrates are the main stimulator of insulin. And they were giving these patients recommending 50% of their diet to be from carbohydrates. You can see all these different arrows I have here pointing where insulin shows up on this metabolic pathway for both fat storage and fat metabolism multiple times. So here's this handout that he has that comes with the audiobook if you do that version, or it's also, these pictures are in the regular book as well. But I think this is very simple for most people to understand. It seems to give us a good success rate. So here are two different versions of a dinner over 600 calories. He has the fattening meal on the left, which is a roasted chicken breast, broccoli, and potatoes, and then the non-fattening or weight loss meal on the right. 2 chicken thighs, more broccoli, no potatoes, and butter. Here are 2 versions of a 700-calorie lunch. The fattening one on the left is a small cheeseburger, fries, and ketchup with a small Coca-Cola. And the non-fattening weight loss meal on the right, a double quarter pounder with cheese, no bun, a green salad, and ice water. Last, 2 versions of a breakfast, just over 700 calories. The fattening one on the left is cereal, half a banana, skim milk, buttered toast, and orange juice. The non-fattening weight loss meal on the right, 3 eggs scrambled with cheese and sausage, 2 strips of bacon, half an avocado, and ice water. So then researchers asked the question, can tirzepatide safely and effectively be given to adolescents for weight loss? And this trial is underway. However, they haven't finished the trial, but hopefully the trial will show that it is effective for type 2 diabetics that are 10 to 18 years old, and then eventually, hopefully, they'll test the same thing with non-diabetic pediatric patients. So semaglutide and tirzepatide are the most effective FDA-approved weight loss medications currently available. And both have not been studied in direct comparison for weight loss, but only in type 2 diabetes. And in type 2 diabetes, the tirzepatide outperforms the semaglutide as far as diabetic numbers go. However, clinically, we have given both to many patients, and the weight loss potential so far seems higher and more consistent with tirzepatide, and surprisingly gives less adverse events compared to the semaglutide. The only caveat to this is the tirzepatide is more expensive than semaglutide. Here is the semaglutide recommended dosing. You start off with month 1 at 0.25 milligrams, and then you do that once a week, and after 4 weeks, you escalate the dose to 0.5 milligrams. And then you do that for 4 weeks, and then escalate to 1 milligram each week, all the way to the 5th month at 2.4 milligrams each week. However, what you typically see is the first month has a lot of adverse events for people. Every time you increase the dose on these steps, people have a spike in those adverse effects. The semaglutide commercially available comes in auto-injectors. So it's a preset dose, and you can't manipulate the dose very well because it's a spring-loaded syringe. So unfortunately, you're unable to precision dose using these auto-injectors. And the same is true for tirzepatide. Also comes in these auto-injectors. Tirzepatide dosing starts at 2.5 milligrams for the first month once a week, and then it moves to, on month 2, 5 milligrams. And then accordingly, month 3, 4, 5, and 6, going all the way up to 15 milligrams if people need more control. So I want to introduce 2 things about common sense dosing with these medications. The first thing to consider is the Hippocratic Oath, and the second thing to consider is the concept of minimum effective dose, or the MED. Physicians, when they first start practicing medicine, pledge to prescribe only beneficial treatments according to their abilities and judgment, and to refrain from causing harm or hurt. The concept of minimum effective dose is that the smallest dose that will produce the desired outcome is the preferred dose. Anything beyond the minimum effective dose is a waste or produces unnecessary side effects. My example for this is boiling water. Once you have water boiling, adding additional heat isn't going to make it boil more. if anything, it's just going to cause more problems. It's going to possibly cause harm to the pan or the receptacle, or also it causes evaporation to happen faster. So, with that in mind, compounded semaglutide and tirzepatide can be received in multi-dose vials so that you could actually precision dose at any amount for the individual needs of each patient using insulin syringes. So supply constraints are an issue for semaglutide and tirzepatide. And in response, Novo Nordisk has already increased manufacturing to meet the already explosive demand for their medication. But with the new population of patients now eligible for the medication, supply constraints likely won't ease up for 4 additional years. And we're seeing the same thing start to happen with tirzepatide. And again, supply constraints are anticipated to be a problem for the next 4 years. The Federal Food, Drug, and Cosmetic Act, the FD&C, allows a drug copy if, number one, there are drug shortages, or number two, a change in the medication can produce a significant difference. So, for example, knowing that these medications have a very common adverse effect of nausea, one strategy is to add something to reduce the nausea, such as vitamin B6. Vitamin B6 has been studied for decades to reduce nausea, and the combination could improve the medication and allow for the legal drug copy. Now, a very common question at this point is, are these medications covered by insurance? Well, when you compound medications, unfortunately, this is the common insurance provider's viewpoint. And again, I'm not agreeing with this. I'm just telling you what we have heard working with insurance companies trying to get coverage. They say typically compounded medications are customized and they can't be approved or viewed as a single entity, and that compounded drugs are designed to treat specific conditions, some of which may be considered off-label. So some practical use ideas or guidelines is start at the lowest dose and even consider lower than what's commercially available. We started using tirzepatide in July of last year at 1.25 milligrams per week, and we have had substantial weight loss, and many people never increased the dose and continued to lose weight for months, all the way even over a year. So the question I have is, if the patient is still losing weight after a month, why increase the dose according to the recommended schedule? If you be patient and ask patients to record their diet and appetite, a smaller dose can go a lot longer of a way. And you can always inject more. If a person's not getting the results that they expected that week and they start to not have or the weight results, or they plateau on their weight, you can always add another injection throughout the week. Just remember, you cannot uninject it. So increase the medications as needed, but my strong recommendation is to take the time to review the patient's diet, appetite intensity, and physical activity before increasing the doses, because the side effects are very real. And the key on this list is appetite intensity. If patients are noticing that they're not hungry, but they have plateaued in their weight loss, then something else is going on with their diet or physical activity. Injections are typically given in the abdomen, upper arm, thigh, or the buttocks. For the abdomen, you want to stay at least 2 inches away from the belly button. On the thighs, you inject them in the sides. The upper arm is good if somebody else is administering the injection. And the buttocks is good if you want to avoid the visual bruising, such as when it's summer or you have swimsuit weather. Some people don't want to have a noticeable bruise, and so the buttocks can be a good choice for that. The injection timing is simply once a week, and it doesn't matter as far as with or without meals. You can have an empty stomach or a full stomach, and that any time of day, morning, noon, or night is fine. If you take it at night, it's not going to cause any problems with sleep. Now, if you are regularly taking it once a week and you want to change the day that you use the injection, according to the manufacturer, they say as long as at least it's been 2 or more days, 48 hours or more since the last dose, you can go ahead and re-inject it. Now, if you're doing the compounded version, you could also inject a smaller amount than you normally would since you just took a dose. So again, another reason that it's nice to have the compounded version of these medications. And if you miss an injection, simply take the next dose as soon as possible. And also, it's recommended that you do not increase your dose at that time if you missed a dose to try to make up for it, because increasing the dose causes more adverse effects. So in a study reviewing multiple semaglutide weight loss without diabetes, they said in this study, we observed that aside from the administration of semaglutide, reduced calorie diet and increased physical activity were also part of the intervention. Hence, semaglutide alone probably will not be able to achieve the about 12% weight loss that they experience. So it's more than just injections. Lifestyle intervention is absolutely beneficial in addition to these injections. So don't forget, higher doses can cause more weight, but can also cause more side effects and also a higher cost. So testimonial number 1, me. So for most of my adult life, I've been about 150 pounds, and I used to run 15 to 20 miles per week. And then I had a very severe injured knee, medial collateral ligament, and I went from 15 to 20 miles per week to 0 miles a week. And I slowly gained 30 pounds over 2 years. In this picture, I'm about 178 pounds. And in July of 2022, I took tirzepatide 1.25 milligrams per week. And in the first injection, I hardly ate what I normally eat. I ate about a third of what I normally did in the first 2 days. My appetite was severely decreased. And when I even ate about only a third of the food I would normally eat, I started to feel nauseous. And then I just put the food away and I thought, oh, I'll come back to it and I'll revisit that, thinking that I might be extra hungry the next day or in the morning. That didn't occur at all. So by the third day, I thought, if I'm just nauseous every time I eat and I'm not hungry, I'm not going to eat until I'm hungry. So I did a complete fast, nothing but water, for 4 days, from days 3 to 7. And I lost 10 pounds in the first week. And I felt amazing. I had tons of energy. And in that, I reorganized my garage. I reorganized my office. And it was summertime in Arizona. And so I was profusely sweating. So by the 4th day of my fast, I started to notice I was getting dizzy when I would go up and down. So classic orthostatic hypotension. So with that, I decided to break my fast. And I had at first a little bit of broth, and that seemed to help after a couple hours, but it didn't quite fix all the dizziness I was experiencing. So I decided to eat a steak. So this is a 16-ounce steak, and it's funny because the people that I work with, they knew I was fasting, and most everybody said, oh my goodness, when you break your fast, you're going to just go crazy with hunger and you're going to gain it all back. That didn't happen at all. So here I broke my fast with a 16-ounce steak. And this is the amount I ate after fasting for 4 days. I only ate about a fourth of it. And then I was full. And also, after just a couple hours, my dizziness went away. And then from there, I just continued eating about a half of what I normally did over the course of 6 weeks. So I took it for 6 weeks. No change in physical activity. I lost 30 pounds. And what was interesting is after the first week or two, I started to reevaluate my eating habits. And I realized that after I was done eating dinner, I had gotten into the habit of looking for something to snack on, either chips or popcorn, things like that. And I thought, why am I doing this? The tirzepatide was able to cut my emotion with eating. And I stopped doing that since. So I haven't retaken the tirzepatide and I haven't gained the weight back. And it's been 15 months since I lost that weight. And by the way, my knee feels way better with 30 pounds less on it. So I also have another testimonial of a 47-year-old male, also took the 1.25 milligrams for 6 months, and then after 6 months he went to 2.5 milligrams, and he's lost over 80 pounds in 1 year, and he's sending me his before and after pictures. I also have a 44-year-old female, same thing, only took 1.25 milligrams and then increased to 2.5 milligrams, and she lost over 90 pounds and now weighs 105 pounds. She lost 46% of her weight. She's also sending me before and after pictures. So semaglutide for heart disease, the SELECT trial. In 40 months, they gave over 17,000 overweight, non-diabetic adults that had a pre-existing cardiovascular disease. Either they had a stroke, heart attack, or other cardiovascular issue going on. And they were randomly assigned to either placebo or semaglutide. Here is the combination of either a cardiovascular death, a heart attack, or a stroke, a non-fatal heart attack or stroke. And all of those, the placebo group, they experienced 8%, whereas the semaglutide group only experienced 6.5% of this combination, of anything in this combination. And it doesn't really sound like a lot, only 1.5% difference, but the reduction ended up being a 20% reduction, which is 132 people avoided one of these endpoints, which aren't good: cardiovascular death, heart attack, or stroke. So this was very significant. Here it is for just looking at the cardiovascular causes of death. Placebo was at 3, semaglutide was at 2.5, but if you notice, at the 36 month is where it really seemed to make a difference. So it seems that you need to do at least 3 years of treatment to really see the difference here in these weight loss injections. And here, same thing, cardiovascular death or heart failure hospitalization, we have 4.1% to 3.4. Same thing at the 36 month. You start to really see this pull away from the placebo group. And all-cause death, 5.2 to 4.3, again at about the 36 month. And here are some other very interesting endpoints. So we have, of course, what we expected to see, a significant body weight change of almost 10%. We see a waist circumference change of almost 8 centimeters. And we also see a blood pressure reduction, as well as a very high reduction in high sensitivity CRP levels, or C-reactive protein levels. This is an inflammatory marker that's linked to countless diseases. In addition, we see a reduction in total cholesterol, LDL cholesterol, and triglycerides, and an increase in the good cholesterol, or HDL cholesterol, which is very difficult to increase in most people. So the semaglutide reduced the risk of cardiovascular events by 20% and marks the first intervention, either a lifestyle or drug, that's ever been shown to reduce the risk of cardiovascular events in patients with obesity or overweight without diabetes. Novo Nordisk, because of this, has filed a request to the FDA to update the label for semaglutide to include people that have a BMI of 27 or higher and a history of heart disease, so that the medication can reduce the risk of additional heart events. The FDA has granted priority review and said that they are going to try to make a decision in the next 6 months. Semaglutide would most likely help high-risk overweight people to avoid a heart attack to begin with, rather than withholding the medication until people experience a heart event. Time magazine interviewed a bunch of researchers and other doctors, and this is what their response was. The data provides the strongest reason yet to start treating heart patients who are overweight or obese, just as doctors address high blood pressure, excess cholesterol, and diabetes in patients. Many heart experts are impressed that this 20% drop that they saw in this semaglutide trial in heart events was on top of reductions they already experienced, because these patients were also being treated with aspirin, statins, and other medications to reduce high blood pressure. Dr. Jastreboff is an associate professor of medicine at Yale, and she said, "We are literally leaping forward from the past to the future at a watershed brought on by highly effective obesity medications." Here we have a systemic review and meta-analysis of over 30 studies looking at bariatric surgery and future cancer risk. Overweight and obesity, we know, increases the risk of certain cancers and cancer in general. And surprisingly, obesity is actually projected to overtake smoking as the leading preventable risk cancer factor in some countries. Obesity is a condition, is what this article argues, that needs to be specifically treated and managed, not just recognized as a risk factor. And bariatric surgery has been shown to reduce overall incidence of cancer, obesity-related cancers, and overall cancer death. Bariatric surgery is specifically associated with the reduction of future incidences of hepatocellular carcinoma, liver cancer, colorectal cancer, pancreatic, gallbladder, as well as specific female cancers, breast, endometrial, and ovarian cancers. Bariatric surgery results in long-term weight loss, and bariatric surgery may decrease overall cancer incidence and mortality and these specific 7 obesity-related cancers. Remember this slide I showed you in the beginning? Tirzepatide compared to bariatric surgery results. So if bariatric surgery can achieve those results because of the long-term weight loss, then tirzepatide most likely will have the same benefits. However, compared to bariatric surgery, tirzepatide has less upfront cost. Tirzepatide is also reversible in case there are adverse effects. And in general, you have less adverse effects than a bariatric surgery, which is a major medical intervention. And on average, probably less expensive than heart disease treatment and cancer. So bariatric surgery, high upfront cost, mostly irreversible. Again, the exception would be the lap band, but more adverse events. Poor quality of life, anemia, lifelong potential for malnutrition, and associated with risk of several late occurring and serious medical conditions that often require lifestyle changes, medication, or even additional surgery. So this new era of weight loss is beyond weight loss. These medications can actually reduce premature mortality. They can reduce heart disease with less strokes and heart attacks, and most likely will be proven to prevent or even reduce cancers. Common question: can semaglutide be taken without injections? Yes. Rybelsus are semaglutide tablets. They come in 7 or 14 milligrams, and so far they have been studied in type 2 diabetes and have shown very consistent results, very similar results to injectable semaglutide. So these medications are oral medications taken daily, and they are very similar, even though in this graph it looks like the oral was much less. However, I do want to point out that the oral study that they did here was only ran for 26 weeks versus this injectable one was ran for 30 when they actually measured the endpoints. But very similar, and they also have similar adverse effects. And the oral is not approved by the FDA yet for weight loss, but it is expected because they've already put in the application to be approved in 2024. And the other thing I want to point out is the semaglutide injection was the one that was proven for the cardiovascular benefit, and the oral has yet to be shown to have those same benefits, but probably will. Zepbound just recently was approved, which is the tirzepatide for weight loss, not just for diabetes. And Guggenheim analyst Seamus Fernandez says, we think it has a strong shot of being the biggest drug of all time. And he also talks about the cardiovascular data and benefits on top of the weight loss benefits, but he doesn't even mention the potential anti-cancer aspects. So with that in mind, it could be even bigger than he thinks. So we talked a lot about many things. Going over a recap here, weight loss injections can be effective as bariatric surgery, achieving real-world 17 to 45% weight loss. These are very real. We see this all the time. And if patients stop taking either the GLP-1 receptor agonist or the dual agonist, there is a high chance of weight regain. And you can safely take a GLP-1 receptor agonist long term. Again, they did that study for 2 years and it was safe for most people. The semaglutide is FDA approved for adolescent weight loss. The risk of thyroid cancer on the label is due to a rat model. However, it has not been shown in the 30 to 50,000 non-diabetic and diabetic humans in the combination of all that research. Semaglutide and tirzepatide are the most effective FDA-approved medications for long-term weight loss. And clinically, tirzepatide seems to produce more weight loss with less adverse effects compared to semaglutide. Tirzepatide is not approved for pediatrics yet. A low-carb, high-fat diet addresses the hormonal problems with weight loss and, in our experience, can outperform study results with the weight loss injections. Highly recommend everyone to start at low doses and only increase if patients reach a plateau. And again, higher doses create more weight loss, but also more adverse events and cost. Both semaglutide and tirzepatide can be compounded and allow for precision dosing, and the medications are more effective with lifestyle counseling. Make sure you check in on your patients, especially if they hit a plateau. Injectable semaglutide has been shown to reduce cardiovascular death, heart attacks, and strokes by about 20%, but again, it takes about 3 years to really start to see those differences. Tirzepatide will most likely prove to have similar decreases to bariatric surgery in future overall cancer incidence, including the incidence of those 7 obesity-related cancers. And finally, tirzepatide is projected to be the biggest drug of all time, even without considering the anti-cancer aspect, which is most likely going to be proven. I hope you enjoyed this presentation. I'm super excited about all of this unfolding in our lifetimes.